Dr. Sonam is going to take us through. Dr. Sonam is assistant professor at Advanced Eye Center, PJ Chandigarh. She will tell us how do we take care of after the trabeculectomy routine, as well as, especially when you've done a repeat procedure, whether this is a limited or a complete external revision. Dr. Sonam, please.
Thank you, sir, for giving me this opportunity. So I'm going to discuss post-resurrection Bleb care. So at the end of the day, after any filtration surgery, our aim is to have a diffuse and functioning Bleb. There are some predictive factors for Bleb revision. First and foremost is your pre-needling intraocular pressure. Any patient who has a very high intraocular pressure, that is considered to be an independent risk factor for failure. And a lack of MMC is also known to correlate with the success of revision. That is, in patients where mitomycin C was not used, then the failure was higher compared to that in which the mitomycin C was used in the primary trabeculectomy. Also, the intraocular pressure in the immediate post-op following in needling or revision is considered to be a good prognostic factor. It is correlated in the fact that the surgeon is able to dissect out the fibrotic tissue to that an extent that the intraocular pressure has come down. So this is considered to be a good prognostic sign. Other than that, multiple needling procedures and patients who are on chronic medications who are more prone to fail, that is again a poor prognostic factor for revision as well. So coming to the morphology of the Bleb, that will give us few clues whether the surgery is going to succeed or not. Bleb vascularization, microcystic changes, and timing of needling, they are considered to be good prognostic signs only in elevated Blebs, but not in all cases. So this is again correlated by the fact that having these characteristics of vascularization and some microcystic changes, it shows that the remodeling phase of the primary trabeculectomy is still going on, and there is a scope of further resurrecting or improving the outcomes. Other cases like non-injected or ischemic Blebs carry a poorer prognosis. Bleb height in some studies show that there is a good prognosis if the Bleb height is good, but only if you do an early needling, those elevated Blebs fare better. While in a flatter or a smaller Bleb, higher failure risk is again seen with revisions. As I already told, the timing of needling, early needling is known to carry a better prognosis in elevated Blebs, but no correlation per se in a flat Bleb. Peroperatively, few surgical pearls that one can keep in mind is to lower the intraocular pressure, since a high preoperative intraocular pressure carries a poorer prognosis, so we must bring down the pressures to a lower side and then perform the surgery. And you can consider either a topical or a periorbital anesthesia depending on the surgeon's comfort as well as the patient's comfort and the patient's cooperation. And we should never use any sharp or tooth forceps while handling the conjunctiva, because you may end up with inadvertent injuring the conjunctival tissue. And also always aim for a watertight conjunctival suture and never leave the OR with an unclosed leak. In the immediate postoperative period, again, as I already discussed, intraocular pressure less than 10 mmHg is a sign of preliminary success. You should always monitor the anterior chamber depth, because in the presence of low IOP, you can have a shallow AC like a choroidal detachment or so. As in any trap procedure or any glaucoma surgery, you should control the inflammation with the help of steroids, cycloplegics, and antibiotics. And around 1 week till up to 1 week of the surgery, inflammation and fibrocystic migration and proliferation is still going on. We must keep on monitoring the intraocular pressure and look at the appearance of the Bleb, and always, as sir has described, keep on giving massage at every visit to form a diffuse Bleb. And you may consider at 1 week again giving a 5-FU injection. At around 2 weeks, fibrous proliferation and vascularization process is ongoing. So again, monitoring the Bleb and looking at the vascularization. You should keep on continuing the steroids in this case and massage as and when needed, along with 5-FU supplements. At up to 4 weeks, the remodeling process is going on. So you should always look for any localization of the Bleb and keep the Bleb always diffuse. And again, keep depending on the morphology and the other inflammatory signs, you should think of giving an injection of 5-FU. At around 6 weeks, the vascularization is going to reduce, and then you see a diffuse bleb, that is well and good, and at that point of time you can think of tapering off the steroids and stopping it. But in some cases the localization process, the remodeling process is giving rise to an encystment or localization, then you should think about using, you consider using an anti-glaucoma medication and continue with bleb massage. At around 12 weeks, if the bleb is encysted, you may plan another needling procedure or revision. But if it's a flat bleb, you can plan a repeat surgery or a glaucoma drainage implant in such cases. And always remember that doing any filtration surgery and a revision surgery is constant. It's a constantly more evolutionary. It's the bleb is always undergoing changes throughout. So it's an ongoing process. So you must keep follow up over a period of many years. I'll just touch upon the few complications of bleb needling and revision. Unlike a trap procedure, hypotony or chronic hypotony is not very commonly encountered, but yes, we do see hyphema, shallow AC, bleb leaks, choroidal effusions, and rarely suprachoroidal hemorrhages and endophthalmitis. So when you look at a shallow AC, when you see a shallow AC, then you must think about the common causes, that is leak, most commonly conjunctival suture, conjunctival wound leak, or a choroidal detachment. So if there's an early bleb leak, think about looking at the cause. If there's a proper Seidels positive, then you can either consider using a large diameter bandage contact lens or a resuturing. So again, at the time of leakage, if you see an early bleb leak, do not jump onto decreasing the steroids, because the steroids are essential in actually halting the fibrosis process. So you should always follow the patient up closely. And as I already mentioned, a bandage contact lens or a direct suturing can be done in such cases. Suprachoroidal hemorrhage is a very rare complication, but we can always prevent it by bringing down the preoperative intraocular pressure low with the help of hyperosmotic agents, and a scleral flap. If it's open, then we should close it immediately along with anti-glaucoma medications. Choroidal effusions mainly get resolved with the help of topical steroids, cycloplegics, and systemic steroids. And endophthalmitis is the most dreaded complication for any ophthalmologist, especially blebitis and bleb-related inflammation and endophthalmitis can present at any point of time after trap surgery or glaucoma surgery. We can prevent it with the help of, by prepping the eye with antibiotic topical drops preoperatively. Installation of betadine is essential, and again, post-operative antibiotics. We should always explain the patient the RSVP sign as described by Professor Parish. That is redness, sensitivity, decrease in vision and pain. So we should tell the patient at any point of time in follow-up, patient should always keep these 4 points. I would like to conclude by saying that maintaining intraocular pressure low with medical management until the needling procedure has a positive effect on success. In case of a secondary glaucoma, patients who are on chronic medications, there's a risk of fibrosis with every surgical intervention, and a better case selection, taking into account the morphology of the bleb and the timing, since primary trabeculectomy may improve the overall outcome after revision. Thank you so much.
Thank you, Dr. Sonam, for excellent presentation. Do we have Dr. Noor Samshia in the hall? Dr. Noor Samshia, there is a keynote address by Dr. Noor Samshia on neovascular glaucoma. If he's not here, I think we can take up the questions then. Are there any questions from the audience? So, Dr. Shishmita, when you do the Aventino procedure, how hard it is actually to negotiate? Because sometimes I find, if you put the cannula even through the ostium, it doesn't actually, it needs to be negotiated hard at times because it won't lift the flap up.
Yes, sir, thank you. It does get a bit tricky initially, but usually if we have managed to get into the sclerostomy, then it's reasonably all right. And one trick that I've learned over time is not to immediately start doing a side-by-side thing, but go straight in, because that's the triangular flap we usually make, and go straight in, and once we are in the subtenon space, then it's easier to lyse it the other way around. So sometimes it does, but once we, I find the trickiest part is negotiating the ostium initially.
I think for a beginner, probably that takes a little while because you're looking at the through an inverted image.
So when you're actually thinking that it's up, it's actually down, and the other way around.
Yeah.
So we did try the direct. We thought that would be easier to just put it in. The problem with that is all direct lenses require the microscope to be tilted and the eye to be tilted too. So since the trabs are superiorly, if you tilt the eye, it goes into the phonics, then you can't see it. It's not the same as doing a goniotomy where you're doing it in the horizontal, then there's no problem. But vertically, there is no tilt, which is why you need an indirect ophthalmoscope, because then the lens is superiorly and you're seeing, I mean the lens is inferiorly and you're seeing the superior, and it's end on. That's the only problem.
I think pushing it through is, I think once you have found the ostium, pushing it through is okay, but I think I find it hard to go the side-to-side movements because your cannula is stuck at 2 points. One is your incision and one is the ostium. So they're the two fixed points basically, and negotiating beyond
so
that becomes a little.
Through,
yes,
and it's in the
to and fro you can do it, but the
then
side-to-side is very
the
difficult to do.
This, and
It's
then,
difficult to do.
then it comes out.
And you use mitomycin before surgery, pre-operative.
Yes,
So is there any difference in using these two, like if you on table or?
So I think the problem with on table would be that there is no way to wash out. All of it will go into the eye. I think that's why they must have made a protocol of a couple of some days prior. Unlike an MMC on table for a trabeculectomy, because there in any case you're opening up your conjunctiva and then everything would be out. But here if it's on table, it's a bolus and then it's all closed and all that MMC is into the anterior chamber. I think that would have been the concern. So I've never used an MMC on table. I've always used it prior.
How many days before you use? 7 days.
They've said 7 days, but logistically it comes to about 3 days prior when we do our pre-ops and then.
Right. Okay. Any questions regarding this one? Yeah, Dr. Shirisha?
Yeah, so why can't we give it in a different location? So MMC on table, but rather than giving it exactly the area of your ostium and the bleb, because we do it on table and we give it in a location which, let's say, if supero-temporally is where I start my needle. I mean, this is not the exact technique that you're talking about, but even there, I guess, supero-nasally we give the MMC injection. So that but it is not in the same plane. As long as you are delineating the planes and it doesn't go into the anterior chamber, it should be okay.
I mean, how would you know that your MMC is not in the same plane?
Because it is in a completely different, so it is superiorly, but it is in a completely different area, because
position.
you know until where your bleb is elevated, right? We do it after the needling. Okay. You know until where your bleb is elevated, so you go beyond that. So we've never had a problem, at least as far as until now, because this is a routine that's followed for several years. So again, like you said, if you have the opportunity of seeing the patient 3 days before and then taking it up, it's okay, but majority of the time they wouldn't. So you do it on the same day in a minor OR, you might as well give an injection in a different location. Of course, not inferiorly like the way you do 5FU, but it is in the same quadrant, but in a different
after the procedure,
location. Yes.
I think I do that for 5-fluorouracil because I use 5-fluorouracil more often after the needling procedure, than mitomycin C. And there we do it, after you have had that bleb, because the bleb is actually subtenons and the 5F you are using is subconjunctival. So there's a bit of a separation in the two. And also you are shifting it a little more either to the nasal side or the temporal side, so you're not directly in that area. And I think, like Dr. Shirisha is saying, it works well. So we haven't had any problems with that.
We always use at the same time needling, even when we do it at the slit lamp. So you do a needling and then a 5F.
You could do that.
Somehow.
But even 5-fluorouracil if it goes into the AC, then there will be a problem. So that concern remains there for both the drugs. Yeah, that's true for both the drugs. Any other issues? I think after this limited, bleb revisions, whether it's a needling ab interno or externo or a limited dissection, important thing is that you can actually make these traps function again. And if trap which has functioned for some, my indicator is that if there's a trap which has functioned for a few years and has failed, that actually has a very good chance of revival by one of these procedures. Now, if your trap has failed very early and there's a lot of fibrosis or there's active fibrosis there's a fibrovascular proliferation still active, those I will not do well with either of these procedures. So I prefer to wait till the eye becomes a little quieter and the vascularization has receded, control pressure with drugs, systemic if required, and let the eye become quieter, and then choose one of these procedures. And as we have tried to explain, the way we choose it, that if you have a bleb, there is a small encysted bleb, that needling will be a better option there. But if you have the flap which is kind of which has sat on its bed, but there's not much of a fibrosis around, I think internal revision would be internal needling would be a good procedure there. But if you have a flap which is stuck to the base and there's some amount of fibrosis as well, I think there you could do the external revision or through a keyhole incision. That would avoid a larger dissection, and you can use the whatever has already been done. The fistula is already made, the iridectomy is already done, flap is already there. So you are using what was done in the previous surgery. You are using that, and you can do a little bit dissection and get away with it. So that's the idea behind this Bleb revision through a keyhole incision. That's Shirisha.
Yeah, one point I would like to add, what has helped me is that once we do the needling revision, not the revision, the needling, the point of entry of the 26 gauge needle, I always close with a 10-0 nylon suture. The reason why I do that is, although it is in a multiple plane, and not that I'm worried about too much of a leak on table, but from day one post-op onwards, I ask them to massage. So digital massage by the patient themselves goes a long way. And how long, when you ask me, usually we see them on day one and then 1 week and 1 month based on the logistics and how far they stay. So I ask them to continue doing the massage. By about a month, generally it settles down. And if it is filtering until then, that means your bleb is going to function in the long term. So that massage, I believe, is very, very helpful. And for that, when you do, I've seen a couple of patients where without the suturing of that tiny little opening, they can leak when you do a massage. So on table, I generally put one single 10-0 nylon suture and then advise digital massage by the patient.
Even with the 26
yes.
Yeah. So I think we should do that, because it's true that these eyes, the bleb the space need to be maintained, because there's a tendency for adhesions, and I think I agree with Dr. Shirisha. Bleb massage is actually very important. We do it every time the patient comes to us, but we don't recommend at home from the patients. Maybe we can try that as well. And it's not only during first 4 or 6 weeks. I massage these blebs even after 1 year or 2 years after surgery, because many times you see there's a good bleb and the pressure is 13 millimeters of mercury, and suddenly patient comes and the pressure is 16 millimeters of mercury and nothing seems to be changing. You massage these blebs, and I think you should be able to break those adhesions. That becomes more diffuse and the pressure comes down. So I have seen that, as I said earlier also, these blebs are not static blebs, they keep on evolving, and over a period of time the bleb won't remain the same. It will, sometimes they go toward the thin cystic side, and sometimes they'll go towards becoming a little flatter and more localized ones. So the blebs which are going towards localization, I think the bleb massage really helps you there. But if they're getting thin and cystic, then you have to wait and watch, and your approach has to be different. So trabecular blebs post-operatively is not 2 weeks, 3 weeks, or 4 weeks. It's a kind of ever going process, and we have to keep that in mind. Any comments? All right. So if there's no more questions, I think
can I ask?
Yes, please.
So can you please elaborate a good technique for a bleb massage that can be done by the doctor, and will it differ from the kind of bleb massage that we advise to be done by the patients at home?
I think Bleb massages actually depends on the purpose for what you are doing. So in the early post-operative period, when they are, these days you suture flaps a bit tight so that the AC is maintained and there's no shallow AC. And the post-operative period, if there's no bleb, then the role of the massage would be to create the bleb. So in that situation, I prefer using a bleb above massage above the surgical site. Just depress the sclera a little bit to create a tangential force and fish mouthing of the flap that you have created, and that forms the bleb. So that's the one way of doing it. But the purpose is different.
Do you use any instrument for the same purpose?
You could use, normally there's no need to use an instrument, but if it's not coming, then you can use what we call McPherson's forceps just to depress the sclera beyond your the margin of the incision. So idea is to create a fish mouth there so that the aqueous comes out. And once it starts coming, it keeps coming. So that's the one way, and one purpose for the bleb. The other is that your bleb is now there, but is getting localized. And there you have to, press directly over the bleb area. So where you have a little bleb blister there, you just press on the blister gently, pull down through the lid, and try to make it diffuse. And you can actually see the bleb. If you're doing it on slit lamp, you can see the the fluid dissecting the subtenons or subconjunctival space, usually subtenon space. So you can see the fluid going through like a hydrodissection. So you can actually see that happening. So you keep doing that to keep the blebs diffuse. I usually don't recommend home, but the home massage would be probably of the second kind, that you through the lid, you could do that. I think some people also
center of the cornea through the lid.
Some people also do from the inferior lid and to push the aqueous through the ostium. But I usually prefer from the superior lid only. Dr. Sirisha?
Yeah. Yes, please.
If I can just add, so while we do it, like if you are doing the massage for the patient for exactly the same reasons which Dr. Pandor said, some of us use tight sutures, some of us use releasable sutures, and then when we want to see which of the sutures is tight, or do we need to release it, or it is just sometimes subscleral heme, which is kind of fibrin, which is kind of sticking the two flaps, with a little bit of massage, the fluid now will start flowing. You don't have to remove the suture. That we do under the slit lamp with the pressure over of your thumb or your index finger. Under microscope, under the slit lamp visualization, two things you do. So you put your finger over the lid and then you give a massage in the area of the bleb. That helps not just to give massage for the fluid to drain, it also shows you how much of force you require, that is you will realize. Number two is how big is the bleb forming. Without realizing, if you do it, too much of fluid will go out and you may even have a flat anterior chamber. You need to be very, very careful when doing that. When we ask the patient to do the massage, we never tell them within the first 3 weeks when the conjunctival edge has to heal. So unless it is a limbal-based trap where your incision is right posterior and you're not worried about bleb leak and things like that, we generally tell them 2 or 3 weeks later, depending on, so if it is a tighter suture and with a minimal massage the bleb is forming very well, or a little bit more indentation is required, then we teach the patient to do it from the inferior part. So we teach them, we said this is an exercise that you need to do the bleb, and they are quite religious. But we explain it to them and we usually ask them to use it. Look up, because cornea should not be in contact at all. Look up, and over the inferior sclera we ask them to give a massage. I ask them to count 5. So give a constant pressure and ask 1, 2, 3, 4, 5 and then release it. Then one more time, then one more time. So 5 times and 5 count each time. And that seems to be helpful. And over the day, yeah. Because you also realize when you do that massage and when you see the bleb is elevated, you make the patient wait and then call them back 2 hours later and see again the pressures will be 30. So this is like in the early post-operative period when removing let's say there is one suture and you don't want to remove it, or removing the sutures too early. If it is risky, high myopes and things like that, then I would actually wait with a bleb massage for a short while before I remove that suture for a permanent decrease in IFP.
Thank you, Dr. Sirisha. Any other questions? Can you use the mic, please?
I have heard that for early conjunctival leaks, when we use tobramycin eye drops 3 or 4 times a day for a period of 1 week or so, I have also seen in my cases that the leaks have stopped. So is there any such similar experience or advice on the same?
I think the small leaks, they will always stop, given an adequate chance. The only issue is that by the time your leak stops, the rest of the conjunctiva may get fibrosed. So any fistula that the eye will try to heal, but by the time the rest of the triad would have failed. So that's why it's very important to address them early. So if you have a micro leak at the limbus in a phonics-based trabeculectomy, many times we would use a large size contact lens that gives you a little pressure there. But if that is not working for 2-3 days, 4 days, we don't wait for more than 2-3 days actually. And if it's not working, consider working in the sense if there's no improvement in the AC or in the Bleb, I think consider doing a resuturing in that area.
Thank you, sir.